Well, good morning. It is morning here in Montgomery. We're doing a training this morning on gestational diabetes for the remote patient monitoring program that we have here for the nurses in the field. My name is Dr. Gary Pugh. I'm the Family Health Services Medical Officer for Alabama Department of Public Health. And this morning we're going to talk about a subject that was dear to my heart when I was in private practice as an OBGYN. I took care of a lot of patients that had gestational diabetes, and so we're gonna kind of go through some of the facts, some of the observations that you need to know about, and hopefully after this is all completed, you'll have a better understanding about what to do as far as monitoring these patients at home. Okay, so let's get started here. We're going to talk about gestational diabetes mellitus. We're going to talk about the general facts to start with. We're also going to talk about postpartum considerations. And at the very end, we're going to talk about other recommendations. We'll have some questions after that, okay? So those of you that are out in the field, here's some basic information that you need to know about gestational diabetes. About 7 to 8% of all pregnancies are complicated with diabetes. Now this is type 1, type 2 diabetes or whatever. About 86% of those cases, however, are gestational diabetes. So only about 14% of those are type 1 and type 2 diabetes, okay? If you understand what that is, gestational diabetes means that they don't have diabetes normally until they get pregnant. Why is that? Because the placenta puts out hormones that helps to break down sugar for the growing fetus, and because of that, sometimes these ladies have a problem taking care of all that sugar in their blood system, and the placenta basically puts out more than their pancreas can secrete insulin for, and so they develop gestational diabetes, okay? So gestational diabetes also places women at risk for preeclampsia. Preeclampsia is where the blood pressure goes up, and sometimes they'll have swelling, protein in their urine. It's a very difficult situation to handle sometimes in pregnancy, can be deadly. Cesarean delivery, it also has an increased risk for developing diabetes later in life. Okay, and we're going to talk about that more in detail later. Their offspring also are at an increased risk of macrosomia, which means growing a larger than normal baby than they would have, okay? And also the babies can develop neonatal hypoglycemia, which means that after delivery, those babies' blood sugars sometimes are really high, and their pancreas kicks in and all that insulin to take care of that, and those babies end up with low blood sugar, and so they have to be monitored very carefully after delivery. Also can help increase the risk for shoulder dystocia. Shoulder dystocia is a problem when the baby is being delivered. Sometimes the baby's so big that the shoulder gets stuck on a vaginal delivery, and so it can cause shoulder dystocia, and birth trauma, as well as stillbirth, okay? Our current guidelines suggest that all pregnant women should be screened for gestational diabetes using blood glucose levels at 24 to 28 weeks of gestation. However, some of the higher risk patients may need to be screened earlier in the pregnancy. So when they first come in to see their physician, a lot of times they'll go ahead and do the first screening at that time if they are in that high risk category. We're going to go over those risk factors here in just a second. But once they find out they're pregnant, they will go ahead and get screened right away. And when those tests are negative, it still is recommended, if they do get screened early, that they follow up with the screening at 24, 28 weeks gestation as well. Okay, because they can still actually develop gestational diabetes. Okay, so considering the risk factors, we test all women early who are overweight or obese if they have a BMI greater than 25 or greater than 23 if they're Asian American. And they have one or more of the following additional risk factors, including physical activity or inactivity where they don't do a lot of exercise, first degree relative with diabetes, and that could be type 1 or type 2. If they have high risk ethnicity or race, example, the African American, the Latinos, the Native Americans, the Asian Americans, and the Pacific Islanders all have high risk race factor, okay? Previously given birth to an infant that weighs 4,000 grams or approximately 9 pounds or more, that would put you again at higher risk the next pregnancy. Previously, if they've had gestational diabetes in their one of their other pregnancies, previous pregnancy, then they are at risk again of getting gestational diabetes in that pregnancy. Also hypertension. Now we're talking about if their blood pressure is consistently 140/90 or they're on medication therapy for that, they are also at high risk. If their high-density lipoprotein cholesterol, which is called HDL cholesterol level, is less than 35 milligrams per deciliter, HDL is the good cholesterol, so it counteracts the bad cholesterol. But if it's less than 35, they're at high risk. If they have a triglyceride level that's greater than 250 milligrams per deciliter, they're also at risk. Women with polycystic ovary syndrome, PCOS, are also at greater risk for developing diabetes because PCOS goes hand in hand also with obesity, okay? If their hemoglobin A1C level is greater than 5.7, a lot of times when those ladies come in for their screening the first time, they will get their screening test. They will also add a hemoglobin A1C level to find out where they're at, okay? And if their level is greater than 5.7, they are at risk for developing gestational diabetes. They can also have impaired glucose tolerance or impaired glucose fasting, which means that their fasting levels, they can't get them down below where they're supposed to be on previous testing. Other clinical considerations and conditions associated with insulin resistance, for instance, a pre-pregnancy BMI of greater than 40, if they have acanthosis nigrans. Now, what is that? This is something that we look at from a GYN standpoint, is consistent with polycystic ovary syndrome. It's actually a subset called Hare-Ann syndrome, which stands for hyperandrogenism, insulin resistance, and acanthosis nigrans. Acanthosis nigrans is this velvety brown area on the back of the neck, and we see that a lot with patients with PCOS or Hare-Ann syndrome. They are at risk also for developing gestational diabetes. If they have any history of cardiovascular disease, they're also at risk. So let's talk about women what they should do if they do have gestational diabetes. Well, if they do get diagnosed with gestational diabetes, the most important thing that consideration that they need to look at is counseling for dietary and exercise, okay? They need to be counseled immediately by a dietitian or a nutritionist, and they need to be put on some kind of exercise program. So at that point, if diet and exercise both fail and their blood sugars are still elevated, then they may need to go on some medication at that time. And that's used for not only the maternal benefit, but also the fetal benefit, because remember we talked about earlier about macrosomia babies, if they grow the baby too big, if they have too much sugar, it just goes hand in hand, okay? If they have too much sugar in their blood, that means there's too much sugar going through the placenta, so the baby gets that effect as well, and they grow bigger, okay? So a macrosomic baby can be affected. So A1 diabetes is considered gestational diabetes that is controlled by diet and exercise, okay? That means that you don't have to worry about getting on medication at that point. If diet and exercise alone will take care of it, you're considered an A1 diabetic, okay, for gestational diabetes. If you have to go on medication during the pregnancy, you're an A2 diabetic, okay? Insulin is still the preferred treatment medication for diabetes, okay? However, There are some women that decline insulin therapy because they don't want to give themselves a shot every time, or their caregiver might decide that they would be unable to safely administer a shot, so then they can actually go on an oral medication, and metformin is actually one of the reasonable alternatives that we use instead of insulin, okay? But insulin, again, is the preferred treatment for gestational diabetes, okay? So most of the screening protocols that we use thresholds for the 1 hour glucose challenge test. Now what that is we call it GCT, 1 hour glucose challenge test. That's 50 grams of oral glucola, which is a drink that they have to drink. And then an hour later, they will check their blood sugar, so they'll be put on a timer. And if their blood sugar is 140 milligrams per deciliter or greater, they fail, okay? If it's less than 140, they've passed, okay? That means their placenta is basically, or their pancreas is basically taking care of that sugar load that the placenta is giving it at that time. If this test, again, is greater than 140 milligrams per deciliter, then they have to be set up for the next test, which is a 3 hour OGTT, which is oral glucose tolerance test, okay? And with this test, we do a fasting blood sugar, and then we do a 1 hour post-glucose and a 2 hour post-glucose and a 3 hour post-glucola, I should say, blood level, okay? And if those are elevated, then they are considered to be gestational diabetes. Now here is a breakdown on this slide of the 3 hour OGTT, oral glucose tolerance test, okay? So basically the patient will come into the doctor's office, they have to come in fasting. This is always a problem, I know. They always have to come in fasting. They want to drink their coffee, they want to drink whatever, or they want to eat breakfast, but they can't do that. And with this test, it's very important that they come in fasting. Now, let me back up. With the 1 hour GCT, they sometimes can go ahead and eat with that, and they'll check sometimes check a fasting and then go ahead and check a 1 hour glucose challenge, and that's a glucose challenge test. So they're thinking that maybe the pancreas is going to take care of whatever they've already loaded with. But I used to be on the kind of the conservative side, and I would always tell my patients to come in fasting for the 1 hour GCT. That throws out all those false positives, okay? So how do we do this? So they come in fasting. Then we check a fasting blood sugar immediately as soon as they come to the office, and then we give them the 100 gram glucola. That's twice the sugar content of the 50 gram, okay? It's very, very sweet. And a lot of the ladies have a hard time doing this, okay? Sometimes they will not tolerate it, and we have to either reschedule or do something different. So they come in, they check a fasting glucose, then they drink the glucola, 100 gram glucola, then set the timer, and at 1 hour, you check a blood sugar level, and at 2 hours and at 3 hours, you check a blood sugar level by the timer from the time they finish their glucola, okay? If the fasting is less than 105, they're okay. If what you're looking for in the 1 hour is less than 190, and at the 2 hour, it should be less than 165, and at the 3 hour, less than 145. Now, so what do you do with this test? A diagnosis of gestational diabetes requires that 2 or more of those thresholds be exceeded, okay? Some clinicians, and this happens today as well, will go ahead and consider them a gestational diabetic if they have just one value out, okay, because they are at risk. The general recommendation is for the daily glucose monitoring 4 times a day. If they are diagnosed as gestational diabetic, then we consider doing glucose testing 4 times a day, okay? And what that means is the patient has a log that they keep up with, a sheet, and it has fasting, 1 hour post-breakfast, 1 hour post-lunch, and 1 hour post-supper. Now there's two different methods that are out there that they can do. They can either do the 1 hour or the 2 hour. In my experience, the 1 hour was much easier. Why? Because patients forget sometimes. Okay, so what we tell them is you check your fasting as soon as you get up that morning, and then as soon as you eat breakfast, go ahead and set your timer. If you have a watch or whatever, clock or whatever, set your timer for 1 hour, and at 1 hour you check your blood sugar again. At 1 hour, the blood sugar should be below 140. If they decide to do the 2 hour test, then it should be below 120, okay? It's very difficult. A lot of times people's lives are very busy, and so a lot of times if they're doing a 2 hour postprandial, they'll forget. Okay, and so it's easier to go ahead and put it all together. So we tell them to do a fasting, 1 hour postprandial of breakfast, lunch, and supper. So 1 hour after each meal. And they need to keep a log of that, okay? And if their values are below 140, that means they're good. Okay, that means their pancreas is working good enough to keep that blood sugar under control. So metformin can help with that. Insulin helps with that as well. And whoever their physician is will kind of guide them on what their insulin, their medication and everything should be. Okay, the dosage as far as that, or the metformin. And if they're following the guidelines and they're doing the diet and exercise, a lot of times that's what they need, okay? So how often do we look at these values? They keep a log of these values on a sheet of paper or whatever and bring them to their doctor's office. Usually in the beginning, once you're diagnosed with it, you do it once a week, because you want to get it under as tight a control as you can because of all the problems that may come up maternal and fetal wise, okay? You can do it more frequently if you need to, and a lot of times the patient actually should know what the value should be, and if they start having some values that are out, they should be able to call their physician's office and relay those values back to the physician's office, and that way they can control them and increase their dosage or whatever they need to do to fix it, okay? All right. Now, we all know this. Sometimes patients are not as honest to us as they need to be, and so they will sometimes fudge on this, so you got to be careful with this. And that's why we want to look at the whole picture. We want a week's worth of values, because, and I've had this happen many times, a patient will come in and they'll give me their numbers, and I'll say, well, what happened here? Oh, I forgot to take my medication. Or, oh, I forgot it was 2 hours after I ate. You know, so you got to ask all those questions. So getting a patient plugged into this is very important. Okay. Okay, the ADA recommends that nutritional counseling by a registered dietitian and development of a personalized nutrition plan based on their BMI for all patients with gestational diabetes, okay? A moderate exercise program is also recommended as part of the treatment plan for all women with gestational diabetes, okay? So any exercise that they do can help control their blood sugar levels, okay? If they don't exercise, it's usually a problem, okay? So let's talk about some of the postpartum considerations now. Carbohydrate intolerance usually resolves after delivery, okay? However, up to about 1/3 of women with gestational diabetes are going to go on and have impaired glucose metabolism or diabetes at postpartum screening. When you screen, we normally will screen about 4 to 12 weeks postpartum, and that's recommended for every single person that had gestational diabetes. Now, the type 1 and type 2 diabetics that they take care of, they don't have to do this. They already know they're diabetic. But we're talking about those patients that come in that did not have diabetes prior to pregnancy. They have gestational diabetes. They are possibly going to develop later in life diabetes. And we do this by doing a fasting glucose test when they come into the clinic, and give them a 75-gram glucola to drink, which is in between the 50 and the 100, okay? And then they do just one test, and it's a 2-hour oral glucose tolerance test, okay? So you get a fasting level and a 2-hour oral glucose tolerance test. The thresholds are for fasting, anything over 125 fasting or a 2-hour glucose level of greater than 199 is considered diabetes, okay? If the fasting level is between 100 and 125 milligrams per deciliter, or the 2-hour glucose test is 140 to 199, they're considered pre-diabetic, okay? If their fasting is less than 100 or their 2-hour glucola is less than 140, then they're considered normal, okay? Now, just because they're normal doesn't mean they're out of the woods yet, okay? Because once the nutrition therapy is initiated, surveillance of the blood glucose levels is required to confirm glycemic control that it's been established, okay? They should be drinking or eating 3 meals a day and 2 snacks, which is recommended by the ADA and also ACOG, to distribute the carbohydrate intake, okay? Carbohydrate intake is important, okay? And make sure that they're using complex carbohydrates and not simple carbohydrates. Now, what's the difference, okay? Simple carbohydrates would be sweet tea, a soda, not a diet soda, but a regular soda, any kind of sweets that they're eating, any popsicles, cake, cookies, that's a simple carbohydrate, okay? It's sugar, flat out sugar. It's going to go straight to the blood system. A complex carbohydrate would be like bread, pasta, rice, potatoes, those kind of things. It's the sugar is there, but it's more complex. The gut has to break it down and be readily available then to the blood system. So to keep those postprandial glucose fluctuations from happening, we always suggest that they stay away from the simple carbohydrates, and if they were going to eat a carbohydrate, it needs to be a complex carbohydrate. Women with gestational diabetes should aim for about 30 minutes of moderate intensity aerobic exercise at least 5 days a week, or a minimum of 150 minutes per week. Okay, I got tongue-tied there, I'm sorry. Okay, screening again at 4 to 12 weeks postpartum is recommended for all women who have gestational diabetes, and to identify these women with diabetes. It's very important that we do that. They also can pick up impaired glucose fasting levels or impaired glucose tolerance, okay? Women with impaired glucose tolerance or diabetes should be referred at that point to a preventive or a medical physician for preventive or medical therapy, okay? So these patients then are going to probably end up having to be on something for a long term, okay, unless they can either one or two things, either fix their diet or start exercising more, okay. ACOG and the ADA, American Diabetes Association, recommend that repeat testing be performed every 1 to 3 years for all women that had a pregnancy affected with gestational diabetes, even if they had a normal postpartum screening result, okay? So just because they got through the pregnancy okay and their results are fine, they're again at risk for developing diabetes later in life. And so every 1 to 3 years, they should get tested again. And that would be, again, the 2-hour OGTT, okay, oral glucose tolerance test, okay. All right, so that's the end. That's the end of the slide lecture. And Greg, I think you've got some questions you want to ask me.
Yes, we have some questions that have been compiled. So the first one is, what are the nutritional goals in gestational diabetes? Okay,
the main nutritional goal is to achieve the adequate glucose levels in the blood, okay? Also to provide adequate weight gain, not only for the mother, but also the baby, so that we don't develop a macrosomic infant, okay? So let's say somebody is pregnant and they're saying, I can't, I need to go on a diet. We don't recommend a diet in pregnancy at all, okay? What we recommend is good, healthy eating habits, okay? And that's why it's so important to get in touch with a dietitian or nutritionist to find out what that might be for you, okay? If that patient has a problem, and we find out they've been drinking a liter of soda every day, there's part of the problem, okay? And so it's really easy when they sit down and talk to a dietitian to make sure that they're on the right path. Ideally, again, we talked about this earlier, that they should eat 3 balanced meals a day and 2 to 3 snacks per day. And again, they want to do that to make sure that they get adequate carbohydrate. Okay. Next question.
Another question, as a nurse in the remote patient monitoring program, what do we need to do for the clients as far as monitoring?
Okay. And as far as monitoring in the RPM program, we want to make sure the client's logging their blood sugars correctly, okay? Now, we talked about the sheet, okay? Usually, the physician's office will give that to them, and it'll have how they want to see it, okay, when they go back into it, because they'll take it back into the doctor's office when they have their visits, okay, and they'll follow up with that. And it's usually 4 times a day. Again, fasting, 1 hour post-lunch, or breakfast, 1 hour post-lunch, and 1 hour post-supper. Sometimes, if they're on insulin, they might also add a 5th time to that, which would be at bedtime. To check their blood glucose levels, okay? And that helps to kind of counteract how the insulin is working, make sure it's working correctly. The patient should know the cutoffs that their physician wants for each one of those numbers, okay? Now, this is not so they can tell a little fib on their sheet, but it's so that the doctor can utilize that information and that data to the benefit for that patient, okay? And they need to understand that. I think education and communication is most important here, because once the patient figures out that their interest is top from this standpoint, then they're probably going to be honest with you, okay?
The next question is, what are your thoughts on the optimal exercise goals for gestational diabetes patients?
As far as what ACOG and the ADA recommend, if they do at least 10 to 15 minutes of walking after every meal, they've done a lot. Okay, that will suffice as far as pregnancy is concerned. Now, after pregnancy, they might be a little more aggressive with it if they continue with diabetes, because they want to drop that weight a little bit. But during pregnancy, we can't do a lot. Okay, but walking is a very good exercise, and the walking in and of itself will decrease blood glucose levels and decrease the hemoglobin A1C. Okay, over time. Now, I want to make a point here. Nurses ask me this all the time. Well, my hemoglobin A1C was up. Well, that's fine and dandy, but hemoglobin A1C levels are not immediate, okay? It's a trend. In other words, blood glucose levels are immediate. It tells you exactly what the blood sugar is at that time that you check it. But you can check a hemoglobin A1C level, and it will tell you, it will take away the fibbing. Because basically, if they say that on their sheet of paper that everything is good, but then the hemoglobin A1C level is 10, they don't add up, okay? So the hemoglobin A1C takes time to decrease or to increase, okay? It doesn't happen overnight. So if a patient is following the rules and they're following the program correctly, and they're doing their diet and their exercise, and they're taking their medication and their blood glucose levels are normal, that hemoglobin A1C level is going to drop. Okay, over time, it's not immediate, okay?
What kind of dietary modifications should we suggest?
Again, it's been suggested that we use, if they do take in carbohydrates, that they take in the complex carbohydrates and not the simple carbohydrates, the sugars. They recommend also that that portion of their diet is between 33 and 40% carbohydrates, and for a daily allowance, caloric allowance, and then the protein should be about 20%, and then the fat should be about 40%. Okay. Again, complex carbohydrates: bread, pasta, rice, cereal, we're talking like oatmeal, that kind of thing, and potatoes. Everybody loves potatoes. Those are recommended over simple carbohydrates. Again, simple carbohydrates are sodas, sweet tea. Down here in the deep southern fried South, we like sweet tea, okay? That's usually not a good thing with diabetes, okay? All right?
What considerations for delivery should we prepare the patient for if they ask questions?
Okay, this comes from ACOG, and ACOG, they recommend that if a patient has an estimated fetal gestational age or weight of 4,500 grams or more, that they consider a cesarean section, or the risk and benefits of a cesarean section. Now, that being said, if this patient has successfully delivered a 9-pound baby in the past, they can probably deliver a 9-pound baby in the future, okay? It's been tried and tested already. If it's a prima gravida, which means it's their first pregnancy and they come in to see you, if they have a gestational weight of 4,500 grams, I'm definitely going to offer a cesarean section. So what kind of problems could they have if they didn't do a C-section? Well, they could have a fetal demise, number one. If they go too long in the pregnancy, they can have a shoulder dystocia, a nightmare shoulder dystocia. They could end up with a fourth degree laceration, which nobody wants, okay, which will affect them later in life usually. And there are several other aspects. They have uterine rupture because they've been trying to push a baby out that won't come out. So those are some of the problems. A cesarean section is not without risk as well, because you've got bleeding, you've got the wound healing and all this kind of, and everybody knows if you're diabetic, your wound healing is diminished. It doesn't heal as well as it should, okay? But it's a lot better sometimes than trying a vaginal delivery that's not going to happen.
Just one last question. Can you go over again how women with gestational diabetes should be screened postpartum? Sure.
So we talked about in pregnancy how these ladies have had gestational diabetes and they're really tired of it. They've done all the testing and everything throughout the pregnancy, and then they get to that 4 to 6 week postpartum, and ACOG says 4 to 12 weeks, that they should be retested, okay? And why is it? It's because if they have gestational diabetes, they're at greater risk in life of developing diabetes, and it's usually type 2 diabetes, okay? So what we do is we have to schedule them a visit, and why do we schedule it? Because we have to do, it's the 2-hour OGTT, oral glucose tolerance test, and they have to come in fasting for that, okay? But I've had this happen many, many times. Patients are tired of it, and they don't want to do it. They put it off, or they say, oh, I forgot and I ate breakfast this morning. Well, that's fine and dandy, but you have to really counsel those patients and tell them the risks that if they don't do this, there's a possibility they're at higher risk for developing diabetes later in life. And that can be a very big medical problem, okay? So we counsel them several ways. We want to make sure they continue their diet and exercise program. That at this point they can now lose weight if they wanted to lose weight to start with. They can get on a diet program or an exercise program as well, and combine the two and lose their weight. But we also will get them scheduled for that 2-hour OGTT. We will check a fasting and a 2-hour postprandial again. The thresholds for the fasting, if it's greater than 125 or greater than 199 at the 2 hours, it's considered diabetic, okay? So, and here's the important factor right here. The diabetic ones are okay. I mean, we know that, okay? If they come back in at 6 weeks and they're diagnosed with diabetes, they go right off to their healthcare provider, and they need to be put on medication and also diet and exercise program. But these ladies that are in the middle in the pre-diabetic, if their fasting is between 100 and 125, or their 2-hour glucose test is between 140 and 199, they're considered pre-diabetic, okay, they actually can change the outcome of that, okay? If they get on a very rigorous diet and exercise program, they can reverse that, okay? That means that their pancreas is still working. It may just not be finished, completely with all the stuff from pregnancy, and that was another question I was going to ask or see if you knew about was that when does it end? Okay, well it doesn't. Okay, usually at the 6-week checkup when we check the 2-hour glucose tolerance test, that will put these ladies in one of those 3 categories. Now the other categories, fasting less than 100 or 2-hour that's less than 140, they're considered normal, okay? But FACOG and the American Diabetic Association still recommend that every 1 to 3 years those patients get screened again, okay, with a 2-hour OGTT, okay? So as an RPM nurse, what are they going to do when they get out in the field? Okay, they're going to test the glucose or make sure that the patient is testing the glucose. One of the most important things that they should do is be sure that their instruments, their glucometer is calibrated appropriately, okay? And so make sure that your glucometers are working correctly and make sure that the ones that are going out in the field, that they're working correctly, and then they can double check the glucometer of the patient, because a lot of times they don't, or they got the wrong test strips. Okay, that's a very important thing to check. Okay, make sure the patient's got the right test strips and those kind of things. But anyway, at the 6-week postpartum or the 4 to 12-week postpartum time, they all need to be retested, and every 1 to 3 years, basically for the rest of their life. Okay, because of their high risk for not only gestational diabetes with another pregnancy, but their high risk for diabetes later in life. Okay. Okay. Any questions that you might have for me for anything else for your nurses?
No more questions.
I hope I covered all that very well.
You did. Thank you very much.
Okay.